for joining us for this episode of Good Tech Compassionate Healthcare titled A Wellness Journey. In this conversation, Gerrilynn Manitowabi, Associate Director at Wikwemikong Health Centre on Manitoulin Island in Northern Ontario, and Nancy Young, Senior Scientist at the Children's Hospital of Eastern Ontario Research Institute in Ottawa, discuss the ACHWM Research Project, a culturally relevant tech-enabled tool that measures and supports the health and wellness of the children in First Nations, Inuit, and Métis communities in Canada.
My name is Gerrilynn Manitowabi. I am the Associate Director at Wikwemikong Health Centre here on Manitoulin Island in Northern Ontario. And I am here with my friend and colleague, Nancy.
Hi, I'm Nancy Young. I'm a Senior Scientist at the ACHWM Research Institute in Ottawa, and it has been an honor and pleasure for me to work on this program of research with colleagues in Wikwemikong, including Gerrilynn. And I'm grateful that this work is funded in part by AMS Healthcare.
So we are here to talk about the ACHWM Research Project.
ACHWM is a bit of a mouthful. It originally stood for the Aboriginal Children's Health and Wellbeing Measure until about 6 years ago when the children gave it a name. And the children call it Anishinaabe, which means, how are you? And Gerrilynn, correct my pronunciation if it's not great.
That's great, Nancy. Anishinaabe.
And so it came to be because leaders in one community identified that many Canadians had been benefiting from data and from understanding their populations through data. And although stories are critically important in communities, funders often want data to support requests for funding and whatnot. So community leaders really were thinking about how do they measure health in their communities, but they really did not like the Western metrics that were available. One of the critical pieces for this project came from a student of mine, Stephen Ritchie, who was doing his doctoral work in Wikwemikong community, needed to assess the impact of an outdoor adventure leadership program and had a raft of Western measures for community members to choose from. And not surprisingly, they didn't like any of them. Most of them were missing spirituality, but they didn't reflect the worldview of community. So that led Mary Jo to make a request that we needed to do better. We needed to do better for the children who are a priority in the Wiki community. Mary Jo and I and a whole bunch of children and some elders and some mental health workers embarked on a journey that has led to a measure that was developed with and for Indigenous children and youth.
Yeah, that's a great background, Nancy. So at the time, Mary Jo, who was the health services director when this was created in 2009, what did she see was the need in the community?
I think she felt that they needed to give children a voice, that they needed children to participate in saying how they were doing if they also wanted children to participate in moving towards wellness. And the strength-based approach was something they really didn't see in Western metrics. Western metrics are about diagnosis and labels and those types of things, but they don't necessarily move you forward. And Mary Jo really wanted to move the children forward towards wellness. And she talked about it as paddling upstream.
From my perspective as a First Nations woman, relatively new to research, and I'm just newly returned to my community, I feel like the ACHWM was well ahead of its time in how it engaged in research with the community. Previously, I was working with a national research institute, and what I heard from a lot of First Nations communities across Canada was their experience with researchers was, they called it helicopter research or helicopter researchers, where they would come into a community, conduct their research, gather the data, and then leave. The communities wouldn't have access to that data, wouldn't have any way to utilize it to implement programs to improve the health and wellness of their community. So what I see with the ACHWM is the data, the research, it stays in the community, and the communities have pretty much total control of the data and how the research is conducted. And this was in 2009, right, Nancy?
We started the work in 2009, but the evolution piece took a long time.
Yeah.
So it's really been a decade that it has taken us to get to the stage by listening to communities where we find ways of letting them control their own projects. So this work started just pre-pandemic. We started to think about how do we make this sustainable so that we don't need a ton of human resources to do it, but also how do we make it accessible and controlled by communities? And so that community control piece was really enhanced, I would say, over the last 2 years.
Right. And a lot of that is, well, it's the communities saying how much support they want, how much control they want, right? With the project, there are 3 different types of agreements that communities can enter into, and each kind of dictates how much support the communities can have from Nancy and the team in terms of data backups, reporting, publication opportunities, and control of the data. So communities have total control. At any time, they can withdraw from the project and all the data that has been collected, which is, I think, super important for communities to have that access, that control. Well, it's the OCAP principles, right? Ownership, control, access, and possession. So the First Nations have control over the data collection process and how the information can be used, which is really great.
So that's been something that we've struggled to do well because OCAP is somewhat theoretical, but we've tried to make it operational and really tried to make it real for communities. We're still learning. We're constantly getting feedback from communities saying that they would like us to do something different or they'd like to see things in a different way. And we sometimes get feedback from academics saying, oh, there are more sophisticated ways to do these things. And we think about it and we say, yes, there are more sophisticated ways to do things. But there's 2 challenges with those. One is they don't necessarily honor the wisdom of the children who created this. And that's the secret sauce in my mind. And secondly, if we use sophisticated statistics and whatnot to report the results, not all the communities have access to statisticians. Very few of them have access to statisticians. So we've actually made this available at a level that's accessible and usable for communities.
I think best tools for the ACHWM is the app, and it makes it really accessible for communities.
So the app started to evolve around 2013, 2014. And it came to be because we were trying to collect data in communities where there were frequently human resources shortages and there weren't extra staff available to do data entry. So we'd had a set of questions that the children themselves created. But if you collect them on paper, somebody had to do the data entry. So we decided to have the children directly do the data entry, and that evolved into a decision that it should be not on a computer, but on a tablet that didn't need Wi-Fi because there isn't always Wi-Fi available. And the children could do it in a way that was friendly to them. 1 question at a time, 1 screen at a time, skipping questions, all the things children like to do. And we created our first app. But it was a happy accident, as Mary Jo would say, because the app really and the tablet really connect to children. They love to sit down and answer questions on the tablet, and they love that it doesn't judge. So there's no funny looks when they give an answer that's unexpected, or there's no looks of concern if there's a negative answer. It just throws them another question and they keep going. The app has actually become a really nice way to connect with children. And in the last 2 years, we've moved it to what's called a progressive web app so that it can be used on any kind of technology, a computer, an iPad, a tablet, an Android tablet. So it's a lot more accessible to more communities.
Do you feel that there are any benefits to the ACHWM that has allowed the project and the team to thrive during the pandemic, which has been a challenge for many communities, especially in the areas of mental health, I would say?
I actually think the timing of the pandemic worked reasonably well for our team because we were at the stage that we were trying to get communities to pause with their data collection so that we could do some upgrades to the app and turn it into the progressive web app, that we could do some upgrades to the website. And when the pandemic came, it forced everybody to shut down the gathering of data from their children because they weren't seeing their children in person. So that gave us a pause that allowed us to do the updates and not impact any community's data gathering at the time. it also gave us the chance with some additional funding from CIHR that we looked at developing other resources to support children and youth that we now share through the same website. So people come to our site for the measurement tool. They also come to our site for free resources, coloring pages that are beadwork that connect to children, emotions charts that have little brown faces that children can see themselves in. So we've put together a whole lot of extra resources that fit with the measurement tool, because there are down times when you're doing the measurement and the kids need something to do. But they also fit for communities who just need to find some Indigenous materials. And everything we've put up under a Creative Commons license on the Resource Hub, so that communities can take down an editable version. They can add their own language to it. They can add their own images to it. And if they're willing, they can share it back with us so we can expand the sharing of material to other communities. So it's become a repository of interesting artwork for children.
And what I really appreciate is that a lot of the resources that were developed are now being translated into Indigenous languages. So we've utilized some of the elders here in Wikwemikong to translate a lot of the resources into Anishinaabemowin, which is Ojibwe language. And we are hoping the team can expand that into other languages in the future. So that is also something we're working on, which just makes the ACHWM more culturally safe for communities, not only here locally in Northern Ontario, but hopefully more culturally safe for other communities across Canada.
And we're hoping, there's a couple of schools that have talked about using the materials in their schools. And we say, great, you can have them, you can use them in the school, but would you please put them in your language? And if you give them back, it's a bonus. If you don't, that's fine. But there's a couple of schools that are thinking about doing that as a student project, to take their language and put it into the resources that we've started. So that's pretty exciting.
If you find these conversations interesting, check out the AMS Healthcare best-selling book, Without Compassion, There Is No Healthcare, Leading with Care in a Technological Age, available wherever you buy your books. 28 outstanding Canadian healthcare leaders confront the challenges threatening our current and future healthcare system. Now back to our conversation.
So I guess I'd like to change the direction a little bit, Gerrilynn, and ask you to speak about, from a community perspective, what makes the ACHWM relevant or interesting to Indigenous communities from your perspective?
Yeah, so the ACHWM is a great tool for communities to utilize, particularly because it's access to a measurement tool that reflects Indigenous worldviews. It's utilized a lot for access to child health resources, which is how we are currently utilizing it here in Wikwemikong. I know there's been interest in other programs of ours to use it in some of our adult programs. So there is the possibility for expansion in that area. Like I mentioned before, it's a great culturally safe tool where the children and the youth, they really see themselves reflected in the tool. It speaks their language. It's a place where they feel safe and they see their culture reflected back at them in the tool, which is something First Nations communities were always looking for.
And you mentioned a little bit earlier that it's different from other research projects, particularly that we didn't take off and fly away again. But are there other ways that you think this project might be informative to other people who are thinking about working with Indigenous communities?
I think what the ACHWM models is the definition of community-led research, community-led information gathering, and access to data. It's not the ACHWM team reaching out to all the First Nations communities across Canada. It's communities reaching out to the ACHWM team. They see a need in their communities and they want to have a culturally relevant tool to measure the health and wellness of their community members. And then that's when we show them the suite of options that they can access for the ACHWM. And they're the community leaders, they're in the driver's seat in how they want to utilize this tool. And we just kind of follow their lead and how they want to progress through the motions, I guess.
So data has come up a lot. And as a Western scientist, I understand the value of data, but I don't think I ever quite appreciated the value that communities placed on data until this work was started. And then I started to get it. But data sovereignty is a really, really critical piece of working with Indigenous communities. So I'm going to ask you, Gerrilynn, if you can speak more about data sovereignty and why it's so essential.
It's important that communities have control of the way that data is collected, gathered, and stored. And it's important for communities to have ownership and control of that data and have a say in how it's disseminated.
So when we think about it, I mean, the data that we're gathering is collected from Indigenous communities, most of them First Nations, not all of them. But the Inuit have IQ principles, which somewhat imply the same things. They are independent nations. They have a right to know about their citizens and control what happens with that data. I don't have a right to write an academic paper and just go off and report on the health of these children. So when we gather data, we have to think about who owns it. And all of the work that we're doing with the website, communities have to sign up to say that they will make sure that they connect with their children, that they use our measure as a way to start good conversations about wellness with their children, so that they use the technology in a good way. But at the same time, we're also making commitments to communities saying the aggregate data, all of the information that's collected is for communities to own and control. So if somebody says to me, I'd like to know what the answers to this question are across all of your communities, I have to say, I'm sorry, I can't provide that. I don't own that data. The communities own the data. Now, I can go back to the communities and say, would we like to collectively pool our data so that we can answer this important question that somebody has asked? And they're completely free to say yes or say no. But the management of that data and what happens to that information is first and foremost the decision of the community and is not the academic decision. And that's a really critical piece for anybody who's working with Indigenous communities, is to find ways that they can access their data. So if Gerrilynn's community is collecting information on their children, she can go into our website at 2:00 in the morning if she so desires and download a report that says, this is how the data looks for the children that have completed it so far. She doesn't need to go through me. There's no gatekeeper. She has control of her project. She can access that information. Those are the kinds of things we have to make sure happen, because quite often the academic paper gets written and then the community finds out about it later.
When communities are engaging with a researcher, our primary goal is not publication or funding. Our primary goal is the health and safety and wellness of our communities and our community members. And in this case, the children in our communities. So with that data, we want to find out what is the base point we're at right now. Are our children well? Are they feeling safe? Are they happy? Where are the areas we can create programming? Do we need to set up interventions in schools? Do we need to identify family parenting programming? So that's the importance of this data for communities. It's always our community members first. And that is all first and foremost, always our priority. So I think the data sovereignty is so important in that aspect, is that we decide how the data is used. That's my perspective anyway. That's why I've come home. I moved home. I've been away from home for so long, getting education and experience, and it's all to come back to my community, to serve my community. And I've been very lucky to be on this, working with Nancy in this respect and learning more about this project. And the priorities are the same there too. It's community driven and it's the health and wellness of the community. And I think that's the great part, what Nancy was talking about earlier about the member portal. It allows community members to access and use the system whenever independently. And there's total control of the data, as Nancy mentioned. There are also resources to help community leaders analyze the data. So if there's a community that isn't so research savvy, the member portal does provide that support in analyzing the data. Nancy, there is an analytic spreadsheet that you were showing me. I wonder if you can talk a bit about that and how does that look?
So one of the things we created was a spreadsheet that they can put their raw data into. And the spreadsheet automatically produces some bar charts for them. So what's the distribution of age for the children? How many are feeling in good or excellent health? It will show them the charts automatically. They don't have to do anything other than put their data into it. It also lets them filter the data. So if they're thinking, I really want a new program for the high school boys. So let's look at the high school boys. Let's hide everybody else and just focus on that group because that's a group that we're trying to plan more services for. They can easily filter it. It doesn't take any magic or excessive knowledge of stats programs. They can simply turn on the filter and say, oh, the boys have needs in these areas. Okay, let's think about programming that we could find that meets those needs. So it's much easier for communities to use it without investing in outside analysts because that doesn't build capacity in communities. The other thing I wanted to come back to is when Gerrilynn talked about serving community first, one of the things that we learned through working with the children way back in about 2011 was that we needed to serve the children first. And serving the children first evolved into a balance chart, which is a form of medicine wheel in which we can graphically show children where their strengths are. So we didn't give kids back numbers to say this was your score or tell them that they were at risk or not. We gave them a picture that looks like a medicine wheel. And that leads to a conversation with somebody local about their strengths. And that was an important piece. Children needed to get the results. If they were going to feed data into the system, somebody needed to do something with the data immediately. So that's how we say thank you to the children for their data, but also how we connect them to local services. And those local services in Wikwemikong were connections to the mental health team. And everybody met a mental health worker through the project. Whether they needed one or not, they got to know the name and the face of a mental health worker. And that for us was a huge success because it built one more relationship. So from a tablet, we actually facilitated a new relationship for support. And we did it because the kids said, we need our answers. You need to tell us how we scored. So we changed it. We didn't quite give them what they scored, but we gave them something that we think is more valuable. And it's a connection to local clinical support if and when they need it. And so the tablet now is the source for gathering data, connects children to local supports. Then it feeds data to people like Gerrilynn, who are the community leaders who are planning group programming or evaluating programming. And only at the end of the day does it ever become the potential data to improve the measure. So sort of a late stage piece that we could use it for with permission from the communities. But the main focus is to support children, support communities. I think this is a compassionate piece of healthcare because it connects children to local workers and it connects children who haven't already found a way to connect. So by doing some work in the community with children at different locations, schools, youth centers, arenas, those kinds of places, it's been able to identify children who need support and connect them to support. It's also been able to connect kids who just need to know who else is out there for me in the community.
But Nancy, it also connects with children who don't necessarily need that support. I think one of the greatest parts of, you mentioned the medicine wheel earlier, and for maybe people who don't know what the medicine wheel is in Indigenous culture, it's a wheel divided into 4 quadrants. And 4 quadrants can have several meanings in many different cultures, but for this purpose, it was separated into the different areas of health and wellness that we identify with in Ojibwe culture, which is mental health, physical health, emotional health, and spiritual. So when a child goes through the app and answers all the questions, a lot of those questions correspond to a different area of the quadrant. So when the questions are done, you're kind of given a score in each quadrant. So it tells the worker that the child is going through the questions with which areas of health that they might need support in, which area of health they're doing great in. So I think that's a great feature is, yes, it shows where children might need help, but it also shows where the children are doing great in, and where we can give them acknowledgement and say, hey, like, I see that you're playing hockey every week and that's great. And how does that helps you connect with your friends? So keep doing that. So that's a great feature as well.
So this project has really taken us from a need for data to a bunch of stories from children about wellness and what it means to them. That took us to questions. Those questions took us to an app. We now have more data for communities, but it's all coming back to having good conversations about wellness. That's where this is going, upstream. Gerrilynn mentioned earlier that we were sort of ahead of our time. And I think we were ahead of our time. And it was probably just the coincidences of the things that were happening at the time that connected us. But I think a key part of that is where Wikwemikong was in their wellness journey. So Wikwemikong, like many Indigenous communities, has had times that they've had challenges with wellness, and there's times that they've been really, really strong and leading. And we started this in a community that was strong and leading and had really good mental health resources. And as much as we would have liked to have started this in 10 communities at the same time, you got to start where there's capacity and there's a desire. So they were ready for research. That's part of what made this work, is they were wanting to move forward. It wasn't us knocking on the door. It was them knocking on the door. So, and the leadership that they brought to the table is why this worked. And it's really hard for academics to sit back and let things evolve. But if you're working with Indigenous communities and you're not Indigenous, which I am not, then you need to follow the directions that they want to take things.
Yeah, and as I mentioned earlier, I'm one of the newest members to the team. I just joined the team probably 6-7 months ago. Mary Jo has since left the health center, so she's not totally a part of the team anymore. We still consult with her from time to time. But the great thing about Nancy and her team is that she's still asked me to be an integral part of the team and asking my perspective and my recommendations as the community leader here in Wikwemikong. So even though Mary Jo was very much part of the initiation and the startup of the project and has left, the project still has that strong community voice, which is very important.
So I think there were a number of things that came together that don't very often come together. If we want to try and create more of this, we have to find a way to incentivize both the Indigenous communities and the academics to come together. And there is an issue of trust with Indigenous communities and Western academics, and that takes time. So Stephen Ritchie had been working with the community for 2 years before I was working in the community. There were other academics who were working in Wikwemikong before Stephen Ritchie. So there was actually a legacy of work with academics. So there was more trust with that community. And academics or academia is a very competitive place where you're always trying to get grant funding and write publications. And if you don't publish your work, there's not positive consequences from the academy that employs you. So there's those pressures, and they don't contribute to successful collaboration, because successful collaboration is all about relationships, and that takes time. I had but an academic from University of Ottawa who I spoke to recently, who's writing a grant proposal. And all of our grant proposals now, you have to talk about if there's Indigenous people involved and how this will inform Indigenous leaders. And you're supposed to talk about your relationships. And I said to her, tell them you are growing them and make me a commitment that you will do this over the 5 years of the grant. Don't tell them you've got them, because you don't, and you're not going to have them by the time the grant goes in. But that's the expectation, right? Is to tick the box. And people need to stop ticking the box and start building relationships. Thank you, Gerrilynn, for joining me in this. It's always a pleasure to have our colleagues from Wikwemikong with us and having their voice part of the conversation. So thanks for stepping up and continuing the tradition. Really enjoyed it.
Miigwech Nancy, is great to participate in this with you.
Thanks for joining us to hear Nancy Young, Senior Scientist at ACHWM Research Institute, and Gerrilynn Manitowabi, Associate Director at Wikwemikong Health Centre, discuss their compassionate wellness tool for Indigenous children. AMS is incredibly proud of our support of the scale-up and spread of this remarkable tool. If you are a researcher working in compassion and technology in healthcare, make sure you check out the many funding programs available through AMS at amshealthcare.ca. Next time, Dr. Ed Spilg of the Ottawa Hospital and Dr. Cinda Rushton of Johns Hopkins discuss their groundbreaking research on moral distress and moral resilience. Join us again for another conversation on good tech, compassionate healthcare.
This podcast was produced by Michael McDonnell of Say Something Productions. Music by Carlo Cruz.